Hello, everybody. Welcome. My name is Angie Peacock. I'm a psychiatric drug withdrawal consultant and a healing coach. I like to bring you conversations that are important to me, topics that relate to people that I see every day. And I'm really excited about this interview because it's going to be a lot in the weeds, a lot about polypharmacy, a lot about how people taper, some nuance when looking at how do I taper correctly and safely for me. So with no further ado, let me introduce Dr. Josef Witt-Doerring.
Yeah, hi everybody. Angie, pleasure to be here.
Yeah. So Josef Witt-Doerring is a board certified psychiatrist with a specialization in identifying and treating psychiatric adverse drug reactions. In 2020, he co-founded a private practice dedicated to assessing and treating patients suffering from these reactions and has since become a trusted expert in the field, particularly when it comes to severe withdrawal injuries. Dr. Witt-Doerring has had the privilege of helping several patients with litigation related to psychiatric drug injuries, thanks to prior experience as a medical officer in the Division of Psychiatry at the FDA. Therefore, he analyzed emergent adverse drug reactions and proposed modifications to drug labeling, giving him a unique perspective on the risks and benefits of psychiatric interventions in both the short and the long term. In addition, Dr. Witt-Doerring has worked at numerous pharmaceutical companies in clinical research and drug safety positions, bringing valuable expertise from both the regulatory and clinical settings to his practice. He completed a fellowship in psychiatric drug development at Janssen and Drexel College of Medicine, as well as his psychiatric residency at Baylor College of Medicine, and earned his medical degree from University of Queensland Medical School in Australia. With a deep commitment to patient education, Dr. Witt-Doerring's long-term mission is to create free, high-quality educational content that empowers the general public to make informed decisions about their mental health care. Thanks to his extensive experience and highly specialized understanding of psychiatric interventions, patients can trust that they are in capable hands when seeking treatment for adverse reactions in his private practice. What do you think when I read all that? It's a mouthful.
Yeah, I was just like, it sounds familiar. I think I wrote that,
Did you do that? You did all that
for my CV or something. Yeah, no,
it was excellent.
But yeah, I'm going to start off, I guess, with the special announcement. It's actually that prior to today, I was actually working in a pharmaceutical company for oncology, and I was also working for another one simultaneously in for psychedelic research as well. As of today, I'm no longer doing either of those roles. So it's essentially kind of going to open up, 50, 60 hours a week to do kind of what you just said, create, resources for people who are doing drug tapering and things like that. So it's very exciting for me professionally because it's the pivot where now, I've kind of burnt the boats. I'm going to just be doing this. And so that's the plan. So I'm excited to see where the extra time that I have can take, what I really see as kind of what I want my life's work to be. So yeah, I'm very excited
Welcome
about
to the
that.
team full time.
Yeah.
Welcome. We need you so badly.
Mm-hmm.
All right. So let's start just from the beginning. What brought you to psychiatry? What was your red pill moment, as you called it on your channel? Like, what opened your eyes? What brought you to psychiatry in the first place?
What brought me? Okay, so first, like, why did I choose psychiatry? I mean, the brief story is that, I had a Chinese mom, and she wanted me to be like a lawyer or an engineer or a doctor, and my dad was pretty academic, and so I ended up just kind of doing well in school and going into medicine. I didn't really know what I wanted to do, but I was very into self-help. I've kind of always been interested in that, psychology, and that was kind of what I was reading through a lot of my, teenage years and early 20s. And I said, well, you know what, maybe I'll kind of join psychiatry because that seems like a medical specialty that's really interested in, psychology, helping people kind of do better, from a mental health perspective. But then I guess the red pill moment was when I actually started practicing clinical psychiatry, and I just realized that it was like so heavy on the drugs, and it was just like this kind of production line where people would come and get their diagnosis, get the medication, and people go, what was like the moment? And I think the moment happened over about like a year or two where I was just, from the get-go it felt off, and then slowly over time it just felt more and more off. And then because I was having these questions, I'm like, and no one had any answers. And, that when I asked questions, it didn't really go well. I started looking for other people, and really I found David Healy. And when I started kind of going down that rabbit hole, he kind of, he opened my eyes, and with respects to, you know, all the drug side effects. I mean, if you look at the DSM, it's like 600 or 700 pages, and there's like 5 pages on side effects in there. The reality is when I'm seeing people in emergency room settings and in hospitals, you know, I don't know, maybe like 20% of the problems are drug related, you know, or have something to do with someone being on too many drugs or being withdrawn from a medication. And no one was seeing this, you know, no one was talking about it. It was just all of these problems were just essentially getting called like mixed bipolar disorder was, you know, the most common thing that I would see. And so, that was the red pill moment, was finding David Healy, Robert Whitaker, and those people, and then hearing their stories and just being like, actually, what these people are saying makes a lot more sense than what I'm being taught, you know, by my residency program.
Wow, that's fascinating. So we both had the same experience where we were in school waking up and like you say something and they're like, we're not talking about that, you know. It was hard to navigate that too as a social worker even. So you brought up an interesting point that I've noticed, because now I've been doing this full time for about 1 year and 3 months, and you know, patterns start to emerge. Every person that I see, I get data points. And so one thing that I see the most of is the inability of a doctor to recognize an adverse reaction, an adverse event, or withdrawal reaction. And it's at that point when the patient is in more trouble because they didn't see the Remeron withdrawal, they are put on Seroquel, or because they didn't see the benzo withdrawal, now they put on an antipsychotic. So can you talk about that, like differential diagnosis? What are doctors missing? Why isn't this part of it? What's happening?
Sure. Yeah. I think one of the things that happens in psychiatry is we have a very impoverished, you know, diagnostic system. It's just symptoms, you know. And that's how most people learn. You know, they don't really learn the character of what certain things look like. You know, depression from, you know, life stresses is very different from the kind of depression or, you know, intense anxiety that someone has when they're going through withdrawal. And you need to notice those things. And so psychiatrists, family medicine doctors as well, and anyone working in this field, they're not really taught to differentiate those two things. So you have a very impoverished kind of classification system, and then it's very easy to kind of just say, well, I guess this presentation could be depression or bipolar disorder, especially if you haven't, I guess, one, you know, you don't know the flavor of withdrawal reactions, and so how do you learn that? How do you learn what these things look like, you know, on the day-to-day basis? I mean, you actually have to take a pretty detailed clinical history. So it's like someone comes in, okay, these are your symptoms. You need to ask them, you know, have you had any changes to your medications lately? You know, have they gone up? Have they gone down? You know, have you added something? And then you want to look at the temporal relationship. I mean, most of the changes will happen within 2 weeks, sometimes sooner, from these changes. And so you're going to look for those things. And then there's actually like a lot of physiologic things that go along with these behavioral states. So, you know, say you put someone on Strattera, this ADHD medication. A lot of the times when these people become manic, they also develop, you know, hypertension. They start sweating like crazy, and so you can kind of pick up these constellations of symptoms, which can allow you to say, you know, this is more likely a drug problem than an underlying condition. And that's the same with the withdrawal type reactions, because they're multi-system problems. I mean, yes, people have intense anxiety and depression, but they've also developed irritable bowel syndrome, sometimes urinary changes, you know, neurologic problems, tingling in their hands, pain, electric shock sensations. And so if you cannot recognize one, like the constellation of symptoms that is a withdrawal reaction, then, you know, what you do is you just end up saying it's depression, you know, treatment-resistant depression, and they get the Seroquel. And then maybe the neurological stuff, they just say, oh, you know, there's some fibromyalgia, or it's like it's chronic fatigue, or they lump it into something else and go, listen, I don't want to hear about it. Go and talk to the other doctor about it. But yeah, so I just think people don't know. They're not described in drug labels well. They're not described in psychiatric textbooks, you know, what these things look like. And so it's just a big fat gap in the training. Yeah.
Yes. And I feel like that is what's bringing us to the next topic I want to talk about. Like, I don't know what to call it. Is this the deprescribing movement, deprescribing science? Like, what is this? You know, there's this new field emerging there's a constellation of us, like Surviving Antidepressants, Adele Farmer, Mark Horowitz doing the research, David Healy. There's all these, Joanna Moncrief, I could go on, So like, where do you see this heading? Like this, what do you call it? Where are we going? Since psychiatry is since psychiatry is really ignoring it mainstream.
I don't know where it's going. I think, well, on the one hand, I think what is imperative is that we make it known that I think a lot of the mental health problems that people think are due to their underlying condition may actually be drug problems. And so for me, what I think is the most important in this space, because we've been writing about this, well, not we, but the collective we, it's been in the medical literature for several years, these benzo problems, since like the early 90s. And I mean, people don't know, the PSSD stuff has been out there for a couple of years now. Royal College of Psychiatrists is already talking about severe withdrawal reactions. And so people don't know these things. So the traditional ways of getting this information out to doctors and the public are not working. So that's why I think social media is really important. So one, I think that to me seems like a really important part of it. And then, when it comes to like the research, I think, Mark Horowitz and Surviving Antidepressants and all these different groups and the Benzo Buddies folks as well. I mean, they've done a really good job at just collecting all of the clinical information on how to do this. And that's, essentially the hyperbolic taper, that seems to be the most useful. And I think that holds true for most psychiatric drug withdrawals. And then kind of on the fringes of that, I guess there's probably stuff that maybe I'm doing a little bit more, which is, what happens when the hyperbolic taper doesn't work, and the person, or you're trying to do it and they have a severe withdrawal injury, and
yes,
you're trying to keep them from not becoming suicidal or signing up for euthanasia or something like that, and then you're just trying to figure out whatever you can, and that's kind of what I see as maybe my contribution to this movement is, what do you do with the people down here where they've tried those things and they're really not working? Yeah.
That's my next question, actually.
Yeah.
Because I think you and I share a lot of the same clients where they go to you for deprescribing and they come to me for coaching just to get them through it. And the thing that I keep seeing over and over again is complex cases. Sometimes they're on 3 to 5 drugs, any little cut, they can't do it. Or they could have a benzo injury. The symptoms are very similar, whether they're on 3 drugs or 5 drugs or 1, but they at some point hit a wall or they develop extreme symptoms and they literally cannot move in any direction. They're terrified. They feel terrible. And I know if you've talked about it, I heard you talking about it kind of like there's some kind of post-traumatic stress reaction, like they're afraid of the next cut. And I've discussed that with a few clients, like how much of this is expectation or fear. I'm not saying that you're making this up, because it's absolutely terrifying, but like, how do we lower that fear a little bit to help you do the next cut? Because you have to be moving. They can't stay like this for 5 years. It's not going to happen. So like, sure. I know you've seen these cases. So like, what do we do? What is that? What is happening?
Yeah, well, let's break that one up. Let's talk a little bit about the PTSD type thing and where that came from. So in my work, I would notice that even people who were doing these micro tapers, I mean, tiny, we're talking like 1% reductions, they would do it. And then for the next 3 days, they would just be really panicked. Anxiety would be super high and they're feeling worse. And I'm not saying that it's not possible, I think, for a reduction like that to trigger these symptoms. But when it's so small and when the person's, and I'm talking like a person who's on a high dose, like 70 of Valium or something like that, where you would expect that a 1% reduction would not, trigger this whole thing. I started thinking about, PTSD type reactions. And I mean, the idea is that you've been so traumatized in the past because of a drug, or maybe you went to a detox and they pulled you off the medication really quickly. And now that has defined like the last 2 years of your life or year of your life of just being in excruciating pain. So obviously when we do a reduction, even a small one, you're going to have feelings about it. And you can have high anxiety because of that. And, as we know, anxiety is going to make everything worse. If you just have baseline akathisia, that's going to go up. So that was something that I was curious about. And so what do you do with that? And you know, something that you could actually do is like a blind taper was what I was thinking might be interesting, where either you could have a doctor send a script to a pharmacist where it says, you know, dear pharmacist, you know, we're tapering from 70 to 40 of Valium. We're doing it over, 9 months. And this is the script. He's going to do, 3 weeks of this, and then he's going to drop. And I need you just to dispense it in a packet that doesn't have any, with identical pills, and they're never going to know.
Yeah.
I mean, that may be an option for something like that to kind of remove that anticipatory anxiety of the dose reductions. And so I think, for situations like that, I think that is an interesting idea, because I do think it's just really triggering for some people to taper even when it's small.
Well, and I think, and that's kind of like, I wanted to touch this later, but it kind of pertains here, but the support groups, they're excellent. They save lives every day, but the worst case scenarios, the worst stories, and they read the worst and they think that's going to be me. And so I feel like that heightens some of the fear. Sometimes I always tell clients, you got to stay in your own experience. You cannot, there's nobody out there that's going to have the same experience as you. You're looking for patterns, but, so I don't know how much of it is like expectation. I know in the chronic pain literature, like chronic pain healing, they always talk about perceived danger can increase symptoms. So I'm like, okay, if that's true for chronic pain, is that true for tapering?
I mean, I think it is for some people. I mean, it would be a different story if we were talking about, if someone's doing like a 5% cut and it's lower down. I genuinely think that can, set some people off just from pure physiologic changes from it. But when you do, especially when you're doing these tiny little micro tapers, I think to me, sometimes that can seem a bit more of a PTSD type reaction.
We're not sure what's going on. And so that makes me think about the central nervous system and destabilization. Like, can you talk about that? Because the way I see it is like all these clients have different symptoms, but they're in the same cluster, but they're all on different drugs. So it's very, like, I know you call it withdrawal reaction, but I'm thinking like, this is a pharmaceutical injury this person has, you know what I mean? Their nervous system is injured. So any little cut of anything, doesn't matter what drug, it seems to kick up the symptoms, they get worse, and then they might calm down. So like, what is that going on? Like, can you talk about the nervous system, or how do you explain it or see it?
Yeah. Well, I guess the first thing is I really should move away from the withdrawal language. Like I know in the FDA labeling, it says protracted withdrawal for the benzo injuries. It's not a helpful way to describe the problem for some people. Yeah, I do think there's two camps. There's like one camp where you're just going through withdrawal. You don't have an injury, so to speak, and you're just coming down and you're moderately uncomfortable on the way down, and then in 2 months, 3 months after you stop, you have a full recovery, and it's been difficult, and maybe it takes 6 to 9 months, and then afterwards, and you're fine. That's just typical withdrawal. If you go up on the previous, if you go down and you feel uncomfortable, you can reinstate and the symptoms go away. That's like one camp.
Yeah.
Unfortunately, that's not the people that I deal with.
Me either.
Yeah. So the people that I deal with have brain damage. I mean, that would be the easiest way to say it. The nervous system is disruptive, and what is happening?
Like, what do we know? This is the question. What do we know about psychiatric drugs? What do we not know?
Yeah. And so, when you have like the withdrawal framework, we'd say, okay, it's protracted withdrawal. It kind of says, yes, you've had changes in your brain, and now they're not adapting back. Maybe you've had receptor upregulation or downregulation, depending on the drug. And now there's just this lag time between, you making the drop and your system kind of readapting. And that's what's producing the symptoms. And I don't think that's really the case for everyone, because, the more I've been around is like, I've seen people who just take like a drug for like a day or a week, and then they develop it.
Yeah.
And so it's, for those people, I'm thinking, and the symptoms are really similar, even from the people who've been on there for 5 years and then come off and developed it. So for that person that's only been on it for like a month or two, it's like, did they really have substantial accumulative over time changes in their brain? I don't know. That's probably not. So then I think about like that whole like epigenetic thing. It's like, where, you know, your environment can change gene expression. And maybe there's just a proportion of people that when they go through these things, whether it's being exposed to this chemical, it actually changes gene expression. It changes the way the drug functions. That's one way to look at it. And then it doesn't kind of change back afterwards, or, you know, they go through an abrupt withdrawal. There's this big kind of surge of excitotoxicity or something. And then, you know, that kind of event then goes and changes, you know, the gene expression and the way things are functioning. And then I guess the last way to think about it is maybe they come off the medication and they're exposed to it and it's just toxic. You know, there's just some kind of damage there that we can't see with a microscope. And it's just like, you know, damage the nerves. So there's many different ways that I've thought about it to kind of account for, you know, why only some people and not others. But yeah, and so anyway, the kind of the unifying path for all of this is you have disordered neurological functioning all over the place, and so that kind of manifests the symptoms. You know, with the withdrawal reactions, it's the pain. You have all these kind of gastrointestinal changes. Your brain is now, you know, from these damaged neurons that are kind of throughout your body, your brain is now kind of overloaded by all of these disordered stimuli that are saying, you know, panic, 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 things aren't working. And then I think that kind of leads a lot to the brain fog as well, and the cognitive deficits, because it's just being flooded by disordered neuronal signaling. And this is all speculative. This is just kind of how I've been thinking about it.
Well, and even this morning I listened to your interview with Kelly about PSSD on YouTube, and she said she went and got that plasma transferese, what is it called? I don't know, but she experienced relief for 6 days, and she said it like removes cytokines and stuff. So I always hear like theories like this, like, okay, maybe it's autoimmune, maybe it's this, maybe it's that. Bottom line is we just don't know. We don't really know.
Yeah, that is insane. You know, her story. I mean, it's if that and you know, in the interview she's getting that done again, something similar. So plasmapheresis, I think, is it's been a while, but I think they remove a lot of like your blood or your plasma, and they kind of like wash it out, and then they bring it back in clean. Don't quote me on that. It's probably wrong, but she's getting IVIG soon, which is a different kind of treatment where they give you these little immunoglobulins that are meant to bind to all of the excess ones floating around your system, and it's used broadly for autoimmune conditions. And if that helps her, then that is going to be, I might as well open up a clinic and start, you know, giving people IVIG for PSSD, because that would be a big deal. And that would teach us a lot about, I guess, why it's been happening to her. You know, like what is going on there, because that would be a kind of an autoimmune type thing going on.
And I did hear there was some researcher in Italy doing research about, he thinks something about when you stop a drug, or the drug can cause a cytokine storm in the gut. So then I always think about, like, is this a gut thing? Like, what? We just don't know. We just don't know, which is scary to me.
Yeah.
You know? Okay, so let's talk about, let's see, I got lots of questions. Support groups and nuance. So I always think about, on Facebook, you know, I was an admin for one of the Facebook groups for about 2 years, and you see comments, you know, and you learn about a person, but there's a lot of nuance when you get like a full clinical picture. So can you talk about like tailoring taper programs for the individual, you know, when you take into account age and ability to handle cuts or longevity of a taper? Like, just talk about the nuance in tapering, where it's not just, it shouldn't just be, you know, 5 to 10% every 2 to 4 weeks for everyone. That's just not good advice, really. So can you talk about that, like length of taper, ability to taper?
Yeah. So what I would say is that I think starting simply. So for the person who's just on one drug, I think it's a lot less complicated. And we'll talk about the more complicated ones later. So for those people, then to me, it's really a question about like, how severe are their symptoms? You know, is this going to be someone that we're tapering who already has protracted withdrawal, or is this someone who has kind of that disordered neuronal firing, or someone that's going to be straightforward? For those people, then it's, for someone who has more of that neurological injury, I'm going to be a little bit more conservative. I'm going to say, let's start at a 5% cut and move slowly and see how you go. For someone who's not having that damage, then we may move a little bit faster. But for both people, it's and you can do this on your own as well with your doctor. But the general principles for the simple case is, 5 to 10% cuts, wait 2 weeks, see what happens. If the dust settles, then move forward. And then, keep a diary if you want to, or just kind of remember it. And then you could speed things up. If you do a cut and then, you only have symptoms for 4 days, but you've been doing 3 or 4 weeks between dose reductions, bring that up to 2 weeks. If someone, the only exception to that, I think, is if someone comes to me and they're older, maybe 70, and they're just like, hey, I just want to come off it and I'm not having any problems, I would probably make that person move like really slow, very hyperbolic taper. And that's really someone who I think probably should come off over 2.5 years or something like that, especially if they've been on it for a couple decades, because the risk of making them worse is, it's not worth being aggressive with it. And for some people, and I've said this before, just leave it alone. If you're 70, 75, 80 and you're okay on this medication and you've been on it for a couple decades, not touching it is perfectly fine as well. I mean, you've up until now, you've already demonstrated that your nervous system can somewhat handle it, and coming off later in life can be very difficult. So
it's funny you bring that up, because I have a cluster of clients. They're like 62, 64, 69, and 72. And I asked the older ones, would you, knowing what you know now, because they're both in withdrawal now, they're off the drugs, knowing what you know now, would you still do this? And they were like, Angie, I didn't have a choice. I had to. I was sick. It's either I'm going to taper and be sick, or I'm going to stay on and be sick. So at least, but it's sad. Those are the last years of their life, and they're spending it in withdrawal. It's horrifying to me.
Yeah. But that would be different. If someone is already in withdrawal and everything like that, then it's like, we do it anyway, because and that's a confusing part of it where I don't actually have answers, but I maybe have questions for you or questions for the audience here. It's like the whole idea of like, is the drug making me worse? Because a lot of people, when they're going through withdrawal, they're just like, it's so bad. And the idea of, has the injury happened because of the drug, or what, the acute withdrawal, and now we're just in recovery mode, versus like, is this drug actually being in my system, prolonging the injury in some way? I mean, that's something I hear a lot of, but I still don't fully understand.
No, and sometimes people will say, like, they're in benzo withdrawal, but they're tapering another drug, and they think that drug is making them sick. But I'm like, okay, but you could have been already sick from the benzo withdrawal. But then they'll say, but maybe it's paradoxical, it's making me worse, it's keeping me from healing. But then I'll say, okay, but if you taper too fast, you're going to get worse. You know what I mean? Like, if you can hardly handle these small cuts, so then they feel stuck. And it's like, I feel bad as just a person critically thinking, like, Angie, don't confuse the situation. But it's like, I don't want them to go so fast that, it ends in suicide. So I'm like, I'm trying to help you. I don't ever tell anybody what to do, but I'm just like, hey, keep this in mind. So yeah, I see that too. Is it paradoxical? Is it toxicity? Is it a previous injury? Is it just because it's the last drug that they're coming off? That's usually the worst. Nobody knows.
Yeah. I want to move on to the other part of that question.
Yes.
What do you do with people who are more complicated? So say someone that comes to you on 2 antidepressants, Seroquel, a lot of gabapentin, which has been thrown on for akathisia, and they're on like a Klonopin, and they go, this is a benzo injury, and I want to taper that. To me, it's sometimes you don't start with the benzo. Let's say the most troubling symptom is, I have electricity and burning in my legs all the time. If one of the other medications they're on is stimulating, maybe it's Wellbutrin or something like that, I might say, hey, let's actually start here, because if we reduce that, that additional stimulation from the medication, that might actually get you more comfortable. And then it's also, seeing what sort of symptoms that you have. So say someone comes to you and they're on 1,200 milligrams of gabapentin because they've developed akathisia, and it's pretty common for people to end up getting put on that, and it hasn't really worked, but now they're complaining of a lot of fatigue, cognitive dulling, sluggishness, but they've only been on the gabapentin for a couple months. It'll be a lot easier for me to remove that gabapentin now, because it's just been started, in a couple months than later on. So I might actually start there before even touching the benzo, which they've been on for a long time. So I try and think about, what's causing the most troubling symptoms, when I look at all of their drugs, and then I'll kind of, start there. And Angie, we've also talked about like tapering several drugs at the same time. And that's like another thing. It's, if you were sticking to like a strict hyperbolic taper, a lot of the times that can take like 2.5 years. And some people who are on 5 drugs, they don't want to do that. And so we may, taking that risk, decide, hey, let's do 2 at the same time. Let's bring down the Seroquel in conjunction with the Klonopin, because they're both bad. The Seroquel can cause the TD problem, so maybe we don't want to wait 2.5 years to start with that. Let's kind of do that in conjunction. That makes things more confusing because you never really know which one you're moving too fast on. But that's like patient preference, and and I totally get if some people want to do that, but it's tricky. Probably the main philosophy I would say is, what are the symptoms that are the most troublesome, and then looking at the drugs that they're on, are there any easy wins here to hit those? And that could be the drugs they're on, it could be getting them to stop caffeine, it could be getting them to stop chewing tobacco, just little things like that. Sometimes even like the dietary stuff can be really stabilizing as well. Stopping gluten, stopping dairy, that's made people a lot better as well. It's not going to transform everything, but overall it reduces, I think, inflammation and the GI stuff.
Yeah, I see that too. It changed for me. I think I was 10 months off and I did like a full paleo primal kind of diet, and I was like, oh my God, my sleep improved, my itching stopped. It was shocking like how much that had been impacting me. So I want to say something about the multiple drugs at the same time, because I just think there's a lot of nuance there where the groups would say only taper 1 drug at a time. I get it. Nobody knows though, and I see people, they're doing all kinds of stuff because they just have to get off, and a lot of them are doing it without medical help because there isn't any specialty for this. And I know of one woman, she made the most excellent point to me that I've never considered, but I really do think she saved her own life. She was on oxygen. It would take her all day to get down the steps, to make a sandwich, and to get back up in bed all day. She couldn't breathe, literally. She's on 5 drugs at the same time. She tapered 5 drugs in 5 months. And I'm not going to say her ride was easy. It was hell. But she's 7 years off now. She's riding a Harley around. She's got her life back. And the way she said it was, Angie, my body doesn't know the difference between 5 drugs. It just knows there's a chemical soup in there, So I just think nobody knows, but there's a lot of clients that I see that they're on 5 drugs or 3 drugs, and a 7-year taper, like, could that make them worse? Or is that even sustainable for them, their family situation, their job? Like, I don't know. To me, it's like a crisis. It's the thing that makes me the most upset at night, when I see these patients. But I feel like I'm beating a dead horse here,
No, they're good points. You can't be too dogmatic about anything, and there's always going to be situations where maybe you just need to move faster. Like, for instance, if someone had like started having a severe reaction to something, and it looked like, maybe they were becoming like catatonic or frozen or something like that. Even if they've been on like a medication for a couple of years, 5 years or something like that, you might just cold turkey it because the evolving toxicity that you're seeing is life threatening. So it's like your patient who was on oxygen. There's always situations there where you can't be too dogmatic again, and then there's also drugs which seem to be more risky than others, like the antidepressants and the benzos. You probably want to be wary of going really fast with those ones. But I mean, I don't see like a lot of, you know, I mean, I'm going to say things and then people are going to contact me, but yeah,
I know you're already going to get like 100
yeah,
emails. Yeah,
yeah.
we already hit those subjects.
No, like, yeah. So I see, I at least see less stuff from the mood stabilizers. I know there's groups out there for people helping them with withdrawal from those things. And so, you know, maybe, you know, gabapentin as well, things like clonidine. I mean, opiates, those kinds of pain medications. There's some drugs that just don't seem to cause as much neurotoxicity as what I see with the benzos. And maybe this is just me seeing it in the antidepressants and the benzos because they're a lot more common. I'm not trying to say that they don't happen, but that's just my perception from who was walking in the door at my clinic. Yeah.
Good point. Because I always wondered that. Why aren't there more antipsychotic support groups? Why aren't there more mood stabilizer? You know, I do have a couple people tapering Zyprexa, but they're on multiple drugs and they're choosing to do that one first because it's more toxic, you know, lithium, things like that. Okay, let's talk about genetic testing.
Sure, yeah.
I think there's multiple kinds though. So can you differentiate between like GeneSight versus something more in depth? Like, what do you think about this genetic testing? You know, take these drugs, they're better for you than the others.
Yeah. So as for, do I think one is better than the other? Like, no, you know, but what I do know is, and the main risk that people need to be aware of is that the genetic testing is nowhere near as sound of a science as it looks when you're looking at the paper, and it's like, you know, take this, you know, green light, you know, orange light, red light for these things. It has the danger to change the clinical, to be like the, you know, the tail wagging the dog, you know, for someone to have this report and then make it really dictate their decisions. Because, like, I mean, if you got the report and you're on Paxil and it's like a red Paxil, you might say, I need to just like get off this one really quickly. And well, let me take a step back there. So the genetic testing comes in two parts. So one is like a metabolic profile. So they will look at your you know, the groups of enzymes in your liver that metabolize the drug, and they'll be able to tell you whether, you know, you're set up to metabolize this in a normal way or a slow way or a fast way. And then they might say, hey, you want a higher dose or a lower dose. And then there's kind of this receptor pharmacodynamic side of it, where they look at the you know, the types of receptors that you have in your brain, and then they'll make predictions on whether, you know, you should take certain drugs based on these receptors. The main point I guess I want to make is they don't strongly predict how someone is going to respond to a drug. I mean, I think they can kind of guide you in a general direction of saying, hey, maybe this one is going to be metabolized in a more stable way. But aside from that, I think it's overblown. And another thing is, like, say, and Angie, I know we're working on a case like this at the moment. Some where, you know, we've got a case and someone has you know, a very unfavorable kind of I guess metabolic profile for several medications, and their interpretation when they were reading it is like, I can't take any of these drugs, it's way too dangerous. But what it really can mean is like, okay, yeah, you can take these medications, but you need to be slower. And you need to be more cautious, and maybe you start at like a quarter of the dose or something like that as you're introducing them. And I don't think that has a huge impact on treating people with you know, bind protracted withdrawal type injuries, because you should be doing that anyway. Like these people, just genetic test or no genetic test, their nervous system is already fried, and it's going to be responding to medications in a very unpredictable way. So every drug that you try on that person should be coming in at like, you know, like a quarter of like the lowest dose, you know, for at least 2 days, and then like half of the lowest dose, and then working your way up to what is considered the normal therapeutic dose. Because, you know, who cares what the genetic test says? I mean, we're talking about someone who has neurological dysfunction. So I don't get them on my patients. I don't think that they're that useful, because when I'm using these medications, I'm already using them, you know, in a very cautious manner, because of the injury. So, yeah.
And I see a lot of people with the withdrawal injuries saying, getting the test now, and I'm like, okay, but it's kind of late. Like, this is what we should have been done before this whole thing started, you know? So it's kind of like entertainment value at this point, just, you know. But I also think, like, it doesn't matter your genetics. These drugs are that powerful that they can mess up anybody, you know?
Oh, yeah. Yeah, you could have green lights across the board, you know, for you know, Prozac, and then you want to take it. But I mean, it just, that's not going to be predictive at all about whether you have these injuries, because you know, the studies that go into this, they're not including people with with antidepressant injuries and things like that, where they're saying, oh, hey, you know, we polled, you know, 1,000 people who had protracted withdrawal. I mean, they don't even recognize it. And, you know, we noticed that they had these specific genetic signatures, and now we have fed this into our evaluation.
Yeah.
That's like,
Right.
I mean, these things, they were built from pretty cookie cutter, you know, clinical trials with healthy people. And so the relevance for our population are, I don't know. Yeah, it can be overblown, but I mean, it looks so good, you know,
It looks scientific. Yeah.
when you see it. Yeah.
Yeah. Oh shoot, I think I just lost my thought. Wait, what was it? Oh, it was something about, oh God, forget it. I'll come back.
Yeah.
Let's talk about reinstatement. No, oh, I know what it was. Okay, so I was one of these people 7.5 years ago. I said my medications saved my life. I need to take them. They are helping me. I didn't realize the extent of my injury until I was off. But I wonder, do you think it's just a matter of time before everyone's affected, or are people okay on psychiatric drugs long term?
People are definitely okay on psychiatric drugs long term. In fact, I saw a lot of people who are just fine. And I've worked with people in professional settings who are just on, you know, SSRIs, and they look like they're doing awesome. I think they can work for some people. I think it's totally overblown how effective that they can be. I think, I mean, there's a lot of problems with how people use them. I like, Joanna Moncrieff is the best for this, because she really talks about, hey, just use them as drugs, you know. And I've never been that convinced with the, with the psychosis literature that says you need maintenance therapy, because that's pretty dicey. I mean, there are people out there with genuine psychotic disorders, and maybe there are some people who need it long term. I'm not going to say maybe there are some people out there who need it long term. I've seen them. Yeah. But I think for many people, it could be something that's more, okay, you're having a flare up of your psychosis. Let's just take this, and then we'll bring you off it gradually. And yeah, so for some people, done cautiously and in the right hands, I mean, they can be very helpful. I mean, that's just that's just really the truth about it. But for other people, they completely ruin their lives. You know, they're mismanaged by by practitioners that don't even ask people about the kinds of effects that these drugs that can have, you know, not just on their mood, but on their work and on their relationships and their love life and things like that. And they can mess your life up in ways that you are not even aware of. And so to me, it was always great. You know, to me, it almost seems insane that the majority of the meds are given by family doctors, and then we think that they're just that safe, because even something as seemingly benign as an SSRI, I mean, what's it doing at work? What's it doing in your relationship? You know, how is this low level kind of mood constriction, you know, reduction in anxiety playing in these different roles? To actually do a proper history on that, and to see if to make sure that it's actually having an overall positive effect on someone, it's highly involved. And you really can't do that in like the last 2 minutes of the appointment after they've talked about all of your cardiovascular stuff. So that's crazy. Drugs. I mean, my other thought about about the SSRIs in particular is that, I mean, that they should only be used for people who have, you know, moderate, high to severe symptoms, because I mean, just the thought that you could give someone PSSD or protracted withdrawal injury from that, I mean, it completely skews the risk benefit. And this is a first line treatment in the US at least. And so, yeah, I have big problems with how antidepressants are used at the moment.
Mm-hmm.
Yeah.
Yeah. What do we know about akathisia? Like, do we know what's going on? How does that relate to that CYP 450? What do we know about akathisia?
I don't know. You know, you should have Chris Page on here because he sent me like a really long I guess draft article he wrote, and he's really in the weeds about what is happening there.
Mm-hmm.
I don't know anything about like the neurobiology of I guess what it is. It's tardive akathisia, you know, the stuff that endures even when you're off the drug.
Mm-hmm.
No, I
We don't know. I'm glad you don't. I'm glad you're humble enough to say we don't know. That's the best answer I can ask for. All right, let's talk about really quick some tapering, some things about getting in the weeds with tapering. So some clients that they're working with their doctor, the doctor is open and willing to do a patient-centered taper. I'll try to help them, like say, you know, ask your doctor about evening out your doses, or what did your doctor tell you? You know, sometimes the doctors know and sometimes they don't. So for instance, I'm trying to think of how to say this. So some clients will be on a short half-life drug and they're only taking it once a day. Some clients are on a longer half-life drug, but they're only taking it once a day, and it might be in their best interest to even it out. What do you think about the half-life in relation to withdrawing safely?
Yeah, I'd say it makes for some people who have the neurological dysfunction, evening out the doses it is really useful. So when I taper someone on Xanax XR, we usually, the first step that we do is get them on the generic non-controlled release version, and then we split it into 4 doses. And that's and I mean I would do that for like a straightforward withdrawal as well, you know, someone without an injury. So I think it makes a big difference. I've had some people who do maybe started on just Valium BID dosing for benzo tapers, and we're still kind of not feeling great. And then when we added in a third dose, split it over 3 times, that seemed to improve their symptoms. And so I think it's definitely something, getting it more evened out for some people, it helps. And I mean, it makes sense. I mean, if you're spreading out the Valium, like instead of it having like big peak down, big peak, you start getting like smaller peaks kind of going like that. And there may be something about that that is less destabilizing to a nervous system that's already kind of unstable. And so I have seen that helped. And that's usually one of the first things that I do. If someone comes to me and they're in really, really severe withdrawal, akathisia, things like that, that's probably one of the safest interventions to do before I start doing some of the other crazier stuff with them, is like, let's like space you out. Let's see how, like, sometimes we'll even replace like their last dose with some Valium if they're having a sleep problem. So we do a combo, maybe Xanax during the day, Valium at night. Let's see what that's like. I mean, the reason to not do full Valium is that sometimes people just get really lethargic and like lose their motivation on it. It really, there's something about like straight up Valium tapers in some people that, they were better on the original drug. So we tend to just try and give it to them at night, especially if they're having a lot of sleep problems. But I would experiment with that.
Is it better for them to do that at the beginning of a taper or once there's problems? Like, I don't know.
You could do it either way. Yeah.
Okay.
You could do it, I might do it at the beginning, but with this other chap, I mean, we started his taper and he was on Valium BID, and the first 3 months he was doing really well. And then he wasn't doing so well. And it was at that point where we said, let's try space it out a little bit. Let's see what happens then. And then he did better. And I mean, is that a coincidence? Like, was he just in a mini wave and I spaced it out and then it just kind of came better. I mean, I don't think so. I've seen enough people in the practice, and I've heard enough people saying that spacing it out was helpful, that I think it can be a real thing for some people.
Got it. All right. We have a whole bunch of questions. Let's try to answer them. I don't know, but let's do like a rapid fire because there's about 5. Okay. One person's asking about, what if somebody's really symptomatic on the drug? Does it really make sense to look at years of tapering, or is 4 or 6 months more appropriate since they're so sick?
Yeah, that's that like hard question again, where it's like, do you already have the injury, or is this drug
Causing the injury?
causing it? I suppose depending on the drug, I mean, I think it's still, you may want to do just still like a cautious taper, but maybe moving like quicker. So, I mean, the full hyperbolic taper where you do 10% of the last, or 5% of the last dose, that lasts a long time, but you might just do 5 or 10% cuts from a dose until you get like a quarter down. You're like, if it's like 60 of Valium that you're coming off, you might just do, I'm going to do like six milligram reductions down to 40, and then I'm going to go 4 milligram reductions down to 20, and then I'm going to get 2 milligram reductions down to 10. And that's a little bit faster, but it's still kind of following something that's generally hyperbolic. And I always think 2 weeks is, it's like pretty tricky to go faster than 2 weeks. Things get dicey.
Yeah. Okay, so the next
Well,
one is, I know you did a whole video about this, about protracted withdrawal and kind of what predicts it. So can you talk a little bit about, I don't even like to use the word withdrawal, protracted injury. That's what I call it, protracted injury. What predicts that? Is it, this person's asking, is it more likely that people with physical symptoms are more likely to end up protracted? So what are your views about protracted for people that haven't seen that video?
So, and now I can't really remember. I mean,
I think I'll tell you, you said usually
yeah.
people that are really sick, when they're tapering, or they're cold turkeyed, or long-term use. Like those are the 3 general categories that can sometimes predict protracted. However, before you even answer this, I want to make sure my audience is not scared. It doesn't mean it's acute level the whole time, guys. Okay. It does calm down. It's not like hellfire every single day for years. Okay. Go ahead.
Well, and I guess the other thing I would tag onto that is like, these are just generalizations as well. We have seen people who have had really severe symptoms recover quite quickly. And so I am kind of at the point where I'm like,
don't answer that.
Does the severity of the symptoms really predict the outcome here? And I'm not sure about that. So in general, it makes sense that if you're older, you're a little bit neuroplastic, and that might be a bit trickier. And just from clinical anecdotes, I mean, rapidly getting tapered off of medication is the most common way that people end up with these things. So, but after that happens to you, does that resolve in 18 months, or does that resolve in several years? I mean, it's hard to know, but they all generally tend to resolve over time. Yeah.
Okay. I'm trying to just like group the questions together. The question I get a lot is, can I heal while I'm still on other drugs? So what do you think about that? Like if this person's still on gabapentin, but they have a benzo injury and they're going to.
So what I think about that is, yes. Yeah. And I see that. I see people who are on cocktails of drugs who are getting tapered and who are healing. So yeah, the answer is, I think for some people, yes.
Perfect. Okay, we're going to end on healing because everybody's now begging for that in the audience. But so what have you seen in the way of healing? I always say this is the only reason I do this job is because I do get to watch people heal. I see it every single day in various ways. So can you talk a little bit about how do people heal from this, or what have you seen?
Slowly. I mean, I see a lot of people heal because they come to me when they're like at their worst. And so, I talk a lot about one gentleman that I work with who was, who had akathisia that was so severe that, I mean, he stopped eating and he ended up, we tried him on a whole bunch of opiates, and then eventually he went to an emergency room and got put on fentanyl, and he was just like, oh my God, this is great. And he was on that for a period of time. But he hasn't needed that in like, I don't know, like 6 or 9 months now. He's eating a little bit more cognitively. He's doing better. You know, when people are really sick with the benzo injuries, and you've seen this, Angie, it's like the looping thoughts,
Oh yeah,
and they just
loops,
keep on
the loop.
talking. It's like pressured looping catastrophic thoughts. And
Yeah.
that's gone down substantially as well. So I just see, the symptoms just generally lessen over time. And I don't know if that's
good
the answer to the
enough. I see
question,
the same.
but
I see the same thing.
yeah.
Yeah. It's just the recovery. You do get your life back. It's
Mhm.
it's hard. It's not fair that it happened to any of us. Nobody can apologize enough for what we've lost, but you do recover. It's not it's not a permanent condition. Everybody says, oh, it's permanent. I mean, do I think some people have lingering symptoms? I'm 7.5 years off and I have lingering symptoms for sure. They don't stop my life. I've learned to live with them and around them. I am happier than I've ever been. So, that's kind of been my experience and what I've seen in other people. Okay, so we're done, but I want you to share about your practice, what you do, how people can find you, how people can contact you and stay engaged with you.
Cool. Yeah. Contact me through, I guess, my YouTube channel. That's if you just want to stop by there and put comments. The overall goal of that channel, it's to be just a repository of my experience doing this kind of work. If someone has the kind of the drive, they can go through there and essentially learn everything that I'm learning. I don't hold anything back on my YouTube channel. There's no additional secrets that you get, if you would come and work with me. So everything is there. I do read the comments, and I try to look at them and find topics, and then I'll make videos about them. And so, just mainly you can get in touch with me through YouTube. If you're having like severe problems and you think that you really, you want someone to have a look specifically at your case, we work in, I think, about 14 states. If you're living in one of those, we can help you. If you're not, you could always come to Utah. We'd love to see you there in person. And that's it. I can't say how excited I am about the social media side of things. I'm going to be really investing a lot of time into hopefully making resources for tapering done with your doctor, what you need to know. Different, I'm also doing a kind of series on these different conditions where maybe I'll interview 10 people with the condition and then make a video that's targeted at a loved one, oh, so your loved one has PSSD, what's it like, and then they could look at the things. So, if you want me to do, so just if you contact me through there and just say what the things that you're struggling with and you're interested in, I'll try and make videos about it.
Awesome. Well, thank you. Do you have any closing words? Anything else left unsaid before we hang up?
Just that I think it's this whole community is at a point where whether you have PSSD, benzo injury, antidepressant problems, we are at a pivot at the moment. There's mainstream recognition of the benzo problems and the PSSD problems. The Royal Colleges of Psychiatrists in the UK is now acknowledging that antidepressant withdrawal can be severe and long-lasting. That's acknowledgement. So I would just say, this is becoming less fringe. It's becoming more widely recognized, and I would just promote it as heavily as you can, with the facts that, this is not fringe stuff. This is stuff that's recognized by mainstream organizations, and it's just, people haven't heard about it yet. So I would just, push really hard to get this stuff out there.
Amazing. All right. Well, thank you so much for being with me today and answering all these questions. I know I feel a little brain dead because it's just so much, so much info, but it's things that I see every single day. And I have tons of clients that were like, please ask them this question, please. This is, and so I think I covered a lot of just the things out there. So thank you so much for your work. Thank you for what you do. I am a subscriber of your YouTube channel. So, and I'm coming through Salt Lake City, but you're going to be out of town, so I don't get that coffee I was promised. But
oh no!
Okay. I know you're going to
come through again, and
I'll come through again. Yeah.
If you need me back here because there's more questions that I didn't get to, you just send me an email and I'll find the time.
Awesome. All right. Thank you, Josef. Thank you, everyone in the audience. Subscribe to both of our channels, and we'll see you later. Bye-bye.
Okay. All right. Thanks. Bye.
Thank you.